AETCM. Today we are going to discuss about epistaxis. 60-year-old gentleman came to ER with complaints of excessive bleeding from nose for last half an hour.
Okay.
Initial 10-second assessment, patient was conscious, oriented and obeys command.
Okay.
Primary survey, airway, no airway obstruction. Breathing, bilateral equal chest movement with respiratory rate of 20 per minute and oxygen saturation of 99% in room air. Air entry bilaterally equal and no added sounds. Circulation, blood pressure of 200 by 100 millimeter mercury and pulse rate of 100 per minute. Good peripheral pulses. We placed 2 large IV cannulas and taken blood samples was taken. Disability, GCS 15 by 15, pupil 2.5 millimeter bilaterally reactive, exposure, temperature afebrile, adjacent to primary survey. ABG was taken, ABG was grossly normal. Secondary survey.
Okay, so fine. So when we are presenting this case, we go through the ABCD pathway and all, that's fine. But when we are practically dealing with this case, first 10-second assessment, we know this is a case of epistaxis, right? Patient is presenting with bleeding from nasal cavity. So it's a epistaxis. Question is whether patient is stable or unstable. What is the stability or instability we are expecting here? Airway compromise. Epistaxis patient can have torrential bleeding, especially from posterior epistaxis, which can complicate airway. And in those patients, especially if this is happening on a patient whose GCS is low, either due to chronic conditions or due to acute intoxications, patient's GCS may be dropped, then in that condition, we may have to secure the airway. That is a primary instability that we are going to see, isn't it? So in that case, airway management is important, and after airway management, our question will be, is breathing adequate or not? Once these two are taken care of, or if these two are not to be taken care of because patient is fully conscious oriented, there is no airway compromise, we really don't want to go to D and E and R, because in circulation itself we have a active hemorrhage. Okay, so the whole idea of primary survey is what? Assess the patient for any acute emergencies. If acute emergencies are there, intervene then. So here we are having active bleeding from nasal cavity. In circulation itself, we have to intervene in that. Question is, in A and B, do we have anything to do? If not, in C, whether patient has hypertension will be the question, but let's be practical. Epistaxis will not cause hypertension. That much hemorrhage will not happen from epistaxis. Then the only question is how we can stop epistaxis. Okay. So we can come to the pathway of treatment in C itself. We don't have to come for D, disability, exposure and primary assess, axillary test, everything. We don't have to do. We can do all that after giving the initial management to the patient. Okay. So this patient presents to you with nasal bleeding. Circulation is there, airway breathing is normal. How will you proceed then?
We ask the patient to bend forward and
Yes.
To avoid the postnasal bleeding.
Basically not to swallow the blood. So patient can bend forward from the waist. It's not bending the head. From the waist the patient can bend forward and
we ask the patient to pinch the nose for 10 to 15 minutes.
Yeah, 10 to 15 minutes, correct. Where should the patient pinch the nose?
And
that's very important. Now, what is the most common area of epistaxis for any patients? Little area, trachea back plexus, right? So that is anterior nasal septum. So we have to ask the patient to clench both ala nasae together over the septum. Okay, so distally, the most distal part of ala nasae should be pressed together over the septum and kept continuous pressure over it for 10 to 15 minutes. That's what we should advise. Patient can press anywhere over the nasal cavity, right? So that is not the thing. Distal most ala nasae should be pressed, and 10 to 15 minutes we can keep the patient in that position and reassess the patient. Most commonly, if it is just a little area bleed or trachea plexus bleed, which is the most common, in 10 to 15 minutes patient will be asymptomatic. If patient has stopped further bleeding, what will you do? what else you need to look for? Your patient has applied the posterior pressure. Bleeding has stopped. Patient has removed the pressure. There is no active bleeding.
Look for any clots.
Yeah, look for clots and examine. Nasal cavity examination. We need to understand from which nostril the blood came, right? First of all, we are applying blindly pressure. We don't know whether it's right nostril or left nostril. So we need to identify the source of bleed. Source of bleed, in all cases of epistaxis, you may not be successful in identification, but you can check for it. How will you check? You need a good light source, and you have to check the septal part for clots or
Bleeding, active bleeding.
active bleeding spot, clots, or any perforations. So then it comes to what are the causes of epistaxis. What are the most common causes? What is the most common cause for epistaxis?
Nasal pricking.
Nasal pricking. So epistaxis most commonly is seen in either children or in elderly adults. Not much among the youth. So age less than 10 or age more than 45-50. That is the most common ages bimodal presentation of epistaxis. Age less than 10, we can think about nasal pricking and local trauma and all those things. And age more than 45, we have to think about other comorbidities also, isn't it?
Anticoagulant drugs.
Yeah. So most common is nasal pricking. Then then basically then it is basic bleeding indications are all due to dehydration of nasal cavities. So dehydration due to non-humidified air. So patient's own hospital environment can have own positive pressure ventilation or own chronic oxygen therapy when it is not humidified, can have crusting over the nasal cavity and bleeding can start from there. Or it can be infection induced foreign bodies. It can be foreign bodies. So if it is chronic foreign bodies, bleeding can be usually associated with purulent discharges. If it is acute, history will be very suggestive. Patient will tell that I have put something up or I have pricked the nose with something up. That history will be there. It can be also associated with the trauma when there is
surgery, head and neck surgery.
Post-surgical hyperemia causing or post-infection hyperemia. The nasal cavity or turbines is rich in blood vessels. So any hyperemia there can cause hemorrhages. Then what else can be there?
Carotid artery aneurysm.
So vascular malformations. So most common what we see is the Kesselbach's plexus, right? So Kesselbach's plexus is made up by septal branch of sphenopalatine artery,
anterior and posterior ethmoid artery,
and facial artery. Superior labial branch of septal branch of facial artery. So these are the three, but these are very smaller arteries, smaller calibers, usually will not cause torrential bleeding. But we also have posterior epistaxis, which is most commonly caused by sphenopalatine artery or branches of carotid artery. So any carotid aneurysms can present with torrential bleeding as such, or patient having vasculitis features, small vessel vasculitis can present with hemorrhages as such, or patient having blood dyskaryosis, any bleeding disabilities. For example,
platelet disorder,
thrombocytopenia. Most common is thrombocytopenia. Then hemophilias, on anticoagulations, isn't it? All these kind of things, von Willebrand disease, all these things can predispose a patient to have epistaxis. They need not develop epistaxis, but there is an increased risk. Then
drugs like aspirin,
anticoagulants, antiplatelets, all these increase the risk. They will not cause, but increase the risk. What else is there? Hypertension. Now, will hypertension cause epistaxis?
No.
Very unlikely hypertension will cause epistaxis, but hypertension increase the risk for epistaxis. Most of the studies, they have found out that epistaxis patients have hypertension. So they are saying hypertension and epistaxis is related, but hypertension can also be due to bleeding causing anxiety, causing increase in blood pressure. So whether hypertension is causing epistaxis or not is debatable. It's not proven. Because when we say hypertensive emergency, we do not say epistaxis as a hypertensive emergency, right? We have end organ damages in a hypertensive emergency. Nowhere it is written epistaxis as a hypertensive emergency. So if a BP more than 180, 100 with end organ damage doesn't produce epistaxis, we can't really link hypertension as a cause. But hypertension definitely will increase the risk for it. So these are the most common causes of epistaxis. And these are the things we should examine in a patient or examine in the nasal septum when we are examining. So any elderly patients or even younger patients, when they present with epistaxis, first and foremost question should be, is it your first episode or not? That is the first question. Because if the patient is rarely having epistaxis or first time epistaxis, most probably it is local traumas rather than a systemic condition. But patient has multiple episodes or episodes which has prolonged presentation, we have to think about other risk factors. For example, our anticoagulation, antiplatelets or any other bleeding disorders, all these things. So angiofibroma, those conditions we have to look for any features of ecchymotic patches in the body, any easy bruising and a nasal occlusion if there is there. Those things we have to check for. Similarly, if patient is having any piercings or any trauma to the nasal septum, history is there, we can look for septal injury or septal perforations which can cause hemorrhages into the nasal cavity. Those things we have to look in examination as such. Okay. Now, what else can you do? How will you manage these cases? Or
in this case, this patient blood pressure was high, sir, 200 by 100.
Okay.
So we gave injection labetalol, 10 mg IV stat.
Okay.
And for active bleeding, we gave tranexamic acid 500 mg
okay.
IV stat. And we kept the nasal prac.
Okay. So, okay, fine. So when we approach this case, the first and foremost question is it an anterior bleed or a posterior bleed we are dealing with? That is the first question, because a posterior bleed is a complication. We have to admit the patient. We have to call END for support, and the patient will require admission and evaluation. Anterior bleeds usually doesn't require an admission as such. We can manage the patient and discharge. Well, according to hospital policies, we can manage the case. So first and foremost, as we told initially, you apply the pressure for 10 to 15 minutes and reassess to see whether active bleeding is there. If active bleeding is there, then we need to give supportive management to the patient and control other conditions that can worsen it. That is when hypertension comes in play. So this patient is having a BP of 200 over 100. It can be a hypertension which is directly complicating a epistaxis, or it can be epistaxis causing increased anxiety to the patient, causing a elevation in blood pressure. Best thing is not to give antihypertensive initially itself. We can give pressure and see whether bleeding gets controlled. If bleeding gets controlled, antihypertensives we can give in oral form. We don't require any IV drugs as such. Oral form is good enough, and adjust the antihypertensives accordingly is okay. But if patient is not getting controlled, we can give an anti-anxiety medication initially, and non-sedative anti-anxiety medication to control patient's anxiety and difficulties. And even if BP is not getting controlled, of course we can go for IV drugs. Better is for a beta blocker like levetolol or a hydralazine, arterial constrictor like hydralazine we can give. That antihypertensive part. What else? We have to give some drugs to decrease the improve the hemorrhage, blood clotting inside the nasal cavity, and cause vasoconstriction inside the nasal cavity. What local drugs can you give?
Adrenaline soaked gauze can be.
Yeah, adrenaline soaked gauze, but adrenaline what we get is 1:1000 dilution. That's a very high dilution, and you are applying it directly to a mucosa. It can get systemic absorption. Better is, anyhow you need to examine the nasal cavity. Nasal cavity being a sensitive area, you know patient is going to be very comfortable in examining. So we can keep gauze or peglets which is soaked in our lignocaine with adrenaline combination. 2% lignocaine with adrenaline combination we have. We can soak it and keep it. So adrenaline will cause local vasoconstriction, while lignocaine will anesthetize the nasal cavity for further inspection. That is one thing we can give. But if you are really worried about even that adrenaline, which is very diluted adrenaline, even that you are afraid of, you can use oxymetazoline. Oxymetazoline will cause vasoconstriction. Local nasal sprays are available. Yeah, decongestions. So we can use a decongestion along with lignocaine for preparation of nasal cavity. So that is one thing. So application of pressure, if not improving, you can give local drugs. If then also patient is not improving, then your question is whether am I really dealing with an anterior bleeding or is there a posterior bleeding? And it's very difficult to identify that from a ER standpoint when patient is having active hemorrhage. Because even though theoretically when we say posterior hemorrhage is increased in volume is there, will have torrential bleeding and all. Anterior bleeding can also be torrential, even the volume is not that much. Torrential bleeding can be seen in anterior hemorrhages also. So how will you, in ER, how will you assess? Easiest way is to pack both nostrils. Pack both anterior nostrils so that whatever anterior hemorrhages is there, it will get compressed and stopped. Even then, if patient is having postnasal drip or acute bleeding is continuing, then we can suspect patient to have a posterior hemorrhage. In such a case, we have to call up ENT for nasal balloon inflation and suppression of clotting. And once clotting is suppressed, they will take the patient for cautery DNE and further cautery examination, but that will come later. But anterior nasal packing most probably we will need to do. What is the most common thing that is used for packing? Marrow. So why not gauze? We can use gauze, right? Why not gauze?
Because marrow expands and occupies the whole space.
Yeah, one is ease of use. You really don't have to be very experienced in using marrow. It's a foam-based substance. You can put it in nasal cavity. It expands to moisture and covers up the entire nasal cavity. So that's one thing. Second thing, other than a gauze, it is not very conduit for organism growth, bacterial growth. So if we keep medical things, staph, strep, everything is there. So gauze and all is a conductive medium for growth. Marrow is a foam base, so it's not very conductive medium for organism growth. So you can keep it there without being afraid of it being unsterile. So marrow is the most commonly used. We can directly place it into the anterior nasal cavity. It will get expanded. Okay. If at all, if it is a posterior bleed, patient is presenting previous history of posterior epistaxis is there, currently presenting with a high volume hemorrhage, patient is spitting out blood each time, how will you approach that? That is when you can give IV drugs. Your tranexamic acid, ethamsalate, all these things have role there. Usually in anterior epistaxis, we really don't have to give tranexamic acid and all, because it's most probably it is local pressure that is required. It will get controlled unless patient has a bleeding disorder. So if patient doesn't have bleeding disorder, we really don't have to give tranexamic acid and ethamsalate for anterior hemorrhages. But posterior hemorrhages, we need to give antifibrinolytic activity agents. We can give that. Similarly, posterior hemorrhage, we can think about airway preservation in early phases itself, especially if ENT is planning for a surgical exploration or a planning for angioembolization and all, we can plan for a early airway stabilization maneuver. Fine. Any other diseases that can present as anterior epistaxis, not anterior, epistaxis as such? Children, usually less than 10 years, 9 years. Any diseases? Carcinoma or something? Angiofibroma is seen in children, right?
Nasopharyngeal carcinoma.
Nasopharyngeal, in adults, nasopharyngeal carcinoma is in children, angiofibroma, right? Angiofibroma can be usually juvenile. Yeah. So in that setting, if patient has multiple episodes, we need to evaluate for that. We can send the patient back. Now, antihypertensive management usually is only required with oral antihypertensives unless patient has torrential bleeding like posterior epistaxis, then and all we can give IV. Otherwise, most probably with anti-anxiety drugs, patient's BP will decrease. That is one of the easiest way to understand whether hypertension is directly causing epistaxis or not. You can give an anti-anxiety drug, which is a non-sedative, because if you give a sedative agent, patient's airway can get compromised. So that is one thing you can think about. Any other thing we need to cover in epistaxis as such? Nothing, right? So most of these cases, if the bleeding is achieved even with marrow seal, we can plan for discharge. You can plan for discharge and review in the ENT OPD in 24 hours. If marrow seal is placed, 24 to 48 hours is the time duration. If at all patient is supposed to get admitted, it should be a posterior bleed or even anterior bleed which is not getting controlled with the marrow seal. Then only we need to call up ENT for admission and further management. Okay. Anything else we need to add or cover? Anything else is there? No drugs, no? Okay. Fine.